Let's start. The active surveillance has clearly changed over the last 10 years. I think that active surveillance is now accepted in most countries, even in the US. Trust me, any discussion about 10 years ago, people would be discussing how crazy you would be to do active surveillance. It's absolutely not the case, even in the US. People understand that we are over-treating prostate cancer. We get that. We discuss the genetics, which are coming on the horizon. We do understand nowadays that PSA is very imprecise, and so deciding on acting in active surveillance patients on PSA only is probably not the best idea. We do have now the MRI, which certainly is of help, but I'll also show you the limitations. We do have some new biomarkers, both at the tissue level and the serum. But more importantly, we didn't have any data. We had single studies, but we did not have data from randomized studies. And although we can argue as whether PROTECT, for instance, is active surveillance or watchful waiting, still, we do have PIVOT, no treatment, PROTECT, no treatment, and we have randomized studies with the outcomes. Now, we still have a lot of questions, and if we didn't have so many questions, we wouldn't be sitting here together to try to elucidate them. One is, what are the molecular events that truly signal that you're going to progress? And what's the risk? How you can't quantify the risk of progression? What are the risks, as we discussed in this 43-year-old gentleman of BRCA? How should we counsel and advise our patients? How to optimally identify the wolves in sheep's clothing. It looks like the Gleason 6, but something else is hiding. And how should we pick them up? How do we integrate the MRI in the current biomarkers into the management? And last but certainly not least, in addition to the very low risk prostate cancer patients, are there intermediate risk patients who actually can be candidates? What is the intervention that you can actually propose to mitigate that risk? One thing which I think no one knows is what's the best follow-up. I would challenge anybody. I'm more than happy that someone tells me how to follow those patients. And can we risk stratify patients to minimize the burden of follow-up in some? So a couple of things which are clear. Virtually no well-documented Gleason 6 ever metastasize. I know the JCI paper in 2013 showed one single case of a man where a Gleason 6 clone in the anterior zone was the one that killed the patient. My answer to that is that there's a lottery, the Lotamax, every week in Toronto. The odds are 1 out of 50 million. So someone actually wins the lottery, but it's just not that common, and you can't base anything based on these odds. For instance, in a large series from Scott, 14,000 proven Gleason 6, they went through each of the pathology. Absolutely no one had met. So I think it's relatively clear that Gleason 6 in theory is protective, at least a low volume. Now, if Gleason 3 pattern, the Gleason 6, doesn't metastasize, so why the hell do you take this into account? Why does the volume matter? How do you find the wolves in sheep's clothing? Well, it's because two reasons. One, you missed at the time of the biopsy or the MR the higher Gleason, and that's one of the possibilities, and then of course over time it's going to grow. Or, and I think it's probably something which is real, when I speak with my absolutely world-class pathologist, who's from the Netherlands, Theo van der Kwast, he and others think that there is over time a certain degree of progression, about 1% over time and per year, and it's kind of real. A lot of things that I'm going to discuss with you today are based and changed compared to the previous years on a European Association position 218. I really advise you and encourage you to read that paper. And several of the sentences are drawn right away. It's not that I like to have a lot of text on slides, but on purpose, I kept them because we're going to discuss them all together. just recently published the position. So, for the EAU, selecting the right patient for the active surveillance, and this their position, is men with low-risk prostate cancer, for sure. Men with longer life expectancy, so if, and I give an example. People tend to forget life expectancies. A man who is 70 nowadays, and I know the data for Germany, I know the data for Canada, someone who is 70 will live on average up to 84, and someone who is 80 will live on average now to 92. And so we really have expanded and extended the life, and very often we tend to underestimate the life expectancy of these people. And because active surveillance basically started in the mid-1990s, so we're about 25 years, we are lacking long-term follow-up, and that's why people say that if you have a life expectancy which is way over 20 years, you probably should counsel your patient that it's likely to be safe, but we just don't have any long-term data. I would challenge anyone to tell me what's the active surveillance outcome at 30 years. We just don't know. The second thing is that when you start a patient on active surveillance, the devil is in the details. You have to report the number of cores submitted, the number of positive cores, the linear percentage and length of involvement with the greatest amount, and also sometimes consider re-review. And too often, I have to admit that I see people who, a patient has a biopsy, the biopsy report comes back, and then you have two cores with 55% and 60% of involvement of a Gleason 6. And then I ask the fellow or the resident and says, oh, that's not a patient for active surveillance. There's over 50% of the core which is involved. What is missing here? What's the information which you, as a physician, when you discuss, should have in addition? I told you a number of cores, I told you the percentage, but what is missing? Absolutely, the total length. Because if your core is only 1 centimeter, and not from 1.5 to 2.2, yes, it is 55%, but it's 55% of a 1 centimeter core. And so every time when I read a percentage, I actually make the effort to turn the pages, look at the description, and look at the length of the core. And this is illustrated here. You see the number of cores, the length. And what you see is that the mark is basically the size of the tumor, and that's a normal core because basically the length of the core was at least 1.5 centimeters, so you can actually take this as a reasonable core. Better would be 2 centimeters. But what is very interesting is that if you ask pathologists to quantify that, you have a really range from 30 to 60%. And we've done that time and again. And so what I'm trying to say here, and the first message, and the position of the EAU was the same, is that just don't look at the number of cores and anything, just decide on the management without going into the details and making sure that this patient fits into these criteria. Of course. The short answer is it's not feasible, practical. I absolutely agree with you. I have the chance to be in a center, like Toronto, which is a big referral with 4 pathologists, and basically whenever they have a doubt among themselves, they re-review right away. So I'm kind of blessed, and I still don't think it's completely feasible. I still think that, say that a core has 60% of involvement, but then the core in total, the length is less than 1 centimeter, I still would, and there's nothing on an MR, for instance, I still would guide clinical decision above simply taking one parameter. What I've done, and I've done that time and again, is a minimal amount of Gleason 4, and then ask the pathologist to re-review to make sure that the 1 or 2% of Gleason 4 is real. That I do often. Do you do the same? If you have a minimal amount of Gleason 4, to ask the pathologist to ensure that it's a Gleason.
Minimal Gleason 4? Yes, of course.
Yeah. So we do the same.
Yeah.
The criteria for the active surveillance are variable. The only one, they can be very, very stringent, like the Johns Hopkins, where you have to have less than 2 cores or 2 cores. Some are larger, like ours in Toronto, or Royal Marsden, where it's less than 50% of the core. Even the PSA, most of the PSA would be less than 10 nanogram per milliliter. But one of the criteria, which is rarely highlighted and which is part of a large prostate cancer active surveillance cohort, is the PSA density. I think it's not unreasonable when you have a patient to, it's not the same to have a PSA of 4 with a prostate which is 80 grams and to have a PSA of 4 in a prostate which is 20 grams and when you had a couple. And I think that's why this has been taken into account. In Toronto, my good friend Laurie, who is basically with Peter Albison, the Pope, and the father of active surveillance, has been including even Gleason 7, but then has a little bit toned down his enthusiasm to mainly Gleason 6, and I'll show you why. At UHN, where I work in Sinai, we usually take patients who have less than 10 of PSA, stage T2 max, Gleason 6, no grade 4 or grade 5, and less than 3 cores, although I'm actually even more liberal. I usually use less than 50%. Anyone who uses 50% cutoff of the course? 1. Who uses 2 or less biopsies? 3 or less? As I said, the prior study uses the PSA density, same parameters with repeat biopsies at 1, 4, and 7 years. Now, our group a couple of years ago with Maria Mizarenko, who's here, decided to ask the question, okay, some people use 2 biopsies, some people use 50%, some people use 3 biopsies, some people use PSAD. It's all over the map. If you use more stringent criteria rather than more liberal criteria, does that translate into an increased risk? And that was the study that they did out of close to 1,000 men, where all these criteria are actually the Royal Marsdens, Miami, UHN, UFT, and the bottom line was that there was no difference. And so I think it's not unreasonable to say that, yes, if you use very stringent criteria, fine, but to think that you're going to have more progression and more risk of death from the disease using more liberal is unlikely to happen. Now, there's a tendency to expand now the indication in the really low volume Gleason 7. And so what's the EAU decision? And I'm going to read the sentence with you. Despite the evidence that some men with Gleason 7 may have favorable final pathology and good outcomes on active surveillance, it is clear that these men have an increased risk of clinical progression and development of metastases when monitored. And so, although it's possible, they are at increased risk. If men with limited Gleason 3+4 at biopsy decide to pursue an active surveillance route, this should be done within a standardized protocol where patients are correctly informed about the lack of robust data and the increased risk of progression. So the EAU says, we know people do it. we don't have a lot of data. You have to warn patients, and there is a slight increased risk of mets. Is anybody here actually offering active surveillance for minimal Gleason 7, 3+4? I remind, it's not part of the discussion, but you may remember about 4 or 5 years ago, we published this autopsy study in the JNCR where we compared, these were men in Japan, Tokyo, where the autopsies were collected, and the prostate, of course, in men who never ever died from prostate cancer. And the same was done in a Caucasian population. And believe it or not, we found 50% of prostate cancer above the age of 60 in both Asian and Caucasian. And on top of that, 51% of the Gleason scores in the Asians were Gleason 7, 3+4 or more, and 25% in Caucasian were Gleason 7, which means that, if you put the math, the pool of people with the disease about the age of 60 is at least 60%. The lifetime risk of being diagnosed with prostate cancer, whether you're in Paris, London, or Toronto, is probably 17%, 1 out of 6. The lifetime risk of dying for prostate cancer is about 2.5 to 2.9% nowadays, correct? A little bit more in Sweden, 4 or 5%, but no more than that. So if you think that among the 60% of men who have prostate cancer, a quarter were found on autopsy, they never even knew that they had prostate cancer with a Gleason 7, that means that there's at least a pool of 10 to 15% of people with some Gleason 7 in the population that will never show up. And that by itself shows that there must be a subset of patients who harbor Gleason 7 prostate cancer and who shouldn't be treated. But the big problem, we don't know who they are. What we know is that the outcomes are uniformly pretty good. And you see here the data at 10 years. The risk at 10 and 15 years of mets in Hopkins, 0.4%, Göteborg, 0.5%, USCF, San Francisco, 0.1%. In Sunnybrook, Laurie's, a little bit higher, 2.5%. So I think it's fair to say that the prostate cancer mortality is close to 0, 10 to 15 years, and it's fair to say that people are safe up to a certain limit. Now, if you look more into details into Laurie's cohort from Toronto here, you have a 10-year specific survival at 98% and a 15-year at 94%. So we still may miss a couple of these people, and I think it's important to warn patients. And the discriminant is actually the Gleason, because Laurie included Gleason 3+4. Most of these guys were actually Gleason 3+4, and that's where the risk, and that's why most likely the EAU decided actually to have this warning for the Gleason 3+4. If you go back, so 22% of the 1,000 patients from Toronto were intermediate risk, and the key findings were that 15 patients died from prostate cancer, 4 died of other causes, and 11 were alive with mets. If you look at the Swedish Göteborg study, same thing. 968 men, 21% of intermediate risk. Among the 341 men with low-risk disease, not a single met or death from prostate cancer. So consistent, you have a Gleason 6 to start with, basically your risk is close to 0. You have a Gleason 7, your risk is still small. The number of people there is still small, but it would be ridiculous to say that there's no risk. And if you look at the predictors, The predictors basically in those 30 men who developed METs out of 900, and 30 were out of 211 intermediate risk. So what's the risk? 30 out of is about 15%, correct? PSA doubling time, less than 3 years. Gleason's 7 or 3 or more cores. If you are in that risk category, probably it's not a great idea to continue your active surveillance. And I think very obviously if you have more than one, if your PSA doubling time goes fast and you have a lot of Gleason 7, just don't do it. Hopkins, these are the JCO paper about 3-4 years ago. Prostate cancer mortality at 15 years, 0.5%. Randomized studies. You all know the PROTECT trial, which randomized patients to active surveillance, radiation therapy, and surgery. What you see is that half of the people who were actively monitored in the PROTECT trial ended up being treated. What you know those curves. Even if you have great eyes and the best glasses, you will not see a difference between the three curves because they are just flat. Nothing happens. This being said, let's be fair. The active surveillance group had more METs. And because of the shorter follow-up up to now, it remains to be seen whether these higher number of METs still in the active surveillance will not translate into something different at 15 or 20 years. But for the time being, just no difference. Even worse, the PVOT study. So, can anybody, I'll show you the PVOT trial data, can anybody tell me what is the biggest criticism of the PVOT trial when analyzing the results? What was the PVOT trial was surgery versus nothing, right? And the first New England showed no difference, right? I'll show you the second one. Okay, fair. But if you're an angry camper in the morning, what's going to be the kind of counter algorithm that you bring to? No? The PIVOT trial was done in a study population, which is kind of skewed because 50% of men in the surgery group died of other causes at 10 years. If you remember any of the patients that you have operated in the last 10 years of radical prostatectomy who died from other causes, just give me a shout. We operate usually when people are healthy, and we remember every single of these poor gentlemen who died of this amount. So it's a rare event. And so to have 50% of this entire cohort that ended up dying from our disease shows that probably is not necessarily completely representative of what we do in the daily basis. Now, that's the mortality, any cause, and radical prostatectomy and observation. Look at that. Nothing happens. Strictly nothing happens. And so the very provocative conclusion from the PIVOT trial was that after 20 years of follow-up in men with low-class prostate cancer, surgery was not associated with significant lower all-cause or prostate cancer mortality. Now, again, it's not absolutely to be translated into the entire population, but it just raises a lot of questions about what we do. Now, another very controversial topic is MR. Multiparametric MRI can be used to detect clinically significant prostate cancer in men on active surveillance in order to improve patient selection, optimize cancer diagnosis, and timing for intervention. This can be done in 3 settings during active surveillance. 1, multiparametric at the time of the initial diagnosis. in patients without multiparametric MRI prior to initial biopsy who are diagnosed with low-risk prostate cancer, suitable for active surveillance, multiparametric is recommended to rule out significant prostate cancer missed by the initial biopsy. And in case of initial biopsy done under guidance of multiparametric, both targeted and systematic are recommended. Okay. So who always performs a multiparametric MR when you start and you commence active surveillance? Okay. Based on what?
Before I do the biopsy, I always ask for
I hear you, absolutely. But so show me a study that is not active surveillance and where patients start with MR and where the outcomes. Good. So at least you do it and then people do it, fine. But at least we agree that there are no data. I can tell you that in Canada, we can't do an MR. We're a public health system, as you know. And that means that reviewing the evidence of the literature, Cancer Care Ontario or has decided, and I have to really support that, I'll show you why, that despite all the trumpeting and blah, 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 of how beautiful things are, there is actually not a lot of rationale to do in multiparametric MR stuff. I don't say it's right. I don't say that you guys should do it are wrong, by no means. I'm just saying that whoever does it, there's no real scientific support, and that some people who are equally interested in patients' health have decided at the nation level not to have an MR for specific reasons. That's all. Multiparametric before confirmation biopsy. So, who in active surveillance would perform systematically a confirmatory biopsy? Who doesn't?
if the MRI is pure one or two.
So, some people here, if the MR is virus 1 or 2, don't repeat the biopsy. Okay? When do you do your confirmatory biopsy?
So just can you show you the active surveillance means already been diagnosed?
Absolutely.
So prior to or one is out of the equation. So this patient already been diagnosed. So the guidelines says you do it at 1 year in the EAU.
Yeah, the guidelines say to repeat biopsies in 1 year. Absolutely. But then the question is, if you have a normal MR, do you still biopsy the patient?
Guided by other factors.
Yeah, MR.
Yeah, but if the PSA is still low, not rising, you can have the patient in discussion. Repeat the MRI to see if the tumor progressing in size or
The
not.
PSA is not. For sake of being clear, Mr. John has 6 at PSA, 2 out of 12 course. His PSA was 6. 1 year later, his PSA is actually 5.8. He did have an MR to start with because he went to see you, and the MR was negative. And then you are scheduling a repeat biopsy at 1 year according to the guidelines. And I'm just trying to understand in this gentleman whether you think that you should base your decision of the confirmatory biopsy on the MR or to go ahead no matter what. Go ahead to a biopsy. Everybody agrees that you go ahead no matter what.
I discuss with the patient. I tell them the guideline says this, and your PSA is this. The second biopsy will carry more risk of infection. If you want the biopsy as per guideline, we're going to arrange it. If you want to be assured, go and no option. So the patient has to be also involved in the decision making.
Could not agree more. Absolutely. Now, here, a multiparametric should be performed before a confirmatory. That's the position of the EAU. So, we know that in Why am I confused? What are the recent data just published which go against the EAU? And Juan Palau will kill me because I'm presenting data which are not what the EAU supports. Jesus. Lori Kloss did the assist trial. I'll show you. The assist trial showed exactly the opposite. People who got MR plus biopsies were no different from the biopsies. Everybody knew and everybody had hoped, like you, that, let's spare the unnecessary biopsies in those people where you see nothing, because then you have carried. And let's see whether people fare better in one of the arms. And guess what? No difference. During follow-up, no robust data support the use of multiparametric instead of standard. So there's an absolute agreement here that during follow-up you cannot replace the biopsies because there are no data. So, as I said, that's what confuses me. I'm going to have a good dinner tonight with Lori, Ursula, and my wife, and I'm going to actually tease him again. And Lori had exactly the same idea as you guys. He wants to know whether MR with targeted biopsies can identify a patient population at greater risk compared to those with systematic and possibly spare people from unnecessary. And so he randomized patients to systematic or MR. And they used the classical RT misfusion targeting system. And the endpoint was the upgrading into the second grade, so Gleason 7, 3 plus 4, 4 plus 3. That's the design of the trial. So patients are registered, the trial is finished, we participated, of course, randomized within 6 to 12 months. Arm 1 was 12 course biopsy at 9, and PSA. Arm 2, MR and confirmation. Good. 273 men were randomized. 64% in the MR group had a region of interest, because it's not because you do an MR that you can see something. So only 2/3 of the patients had a region. 23% of patients with systematic biopsy had upgrading, compared to 21% in the MR, which was targeted plus systematic. No difference.
Sorry, were the systematic biopsies performed only dorsally or also ventral? Sorry, the systematic biopsies, were they, in our protocol, we have to perform at the second time, at the confirmatory biopsies, we usually perform them ventral. And at the first time we do them in the dorsal. Is that the same here?
The reality is that it was actually all over the map. And so Sunnybrook was more, because it was both London, UHN, and Sunnybrook, there was no systematic protocol where to perform the biopsies at repeat. But you're right, some people went more ventral and some people more dorsal. I think so. It could be also a reason for differences, because there were differences between the three groups. You're right.
So, can I ask a question?
For sure.
So why is there no difference? Because MR doesn't reflect where we put our biopsies. MR fusion does not work, in our opinion. You need to have real-time knowledge of where you put your needle. And you can't do this with MR fusion. You can count on proximity to the lesion,
doesn't need any help.
And the second thing, you don't have unfortunately. Yeah. And so the second thing is that I'm going to show you a couple of examples of pilots 5 with Leeson 6. Every Tuesday afternoon we have a conference, and every Tuesday afternoon we discuss pilot 5 lesions, biopsies, sure you're in the target, fuse, or sometimes even under the robots in Toronto, on the MR, and it's still Leeson 6. And so people forget that it's not because you have a pilot 5 that you're going to have a high rate. That's not true. If your cells are very back to Leeson 6, you still may end up with a Leeson 6. I can't really tell you why there were so many differences. It was an astonishment for everyone. I agree. But I think that what people had hoped that you're going to pinpoint the differences or that you're going to spare patients for the MR is maybe possible, but not supported by the data. That's basically And what I think MR is pretty good at is pinpointing the tumors which are anterior. We know that. If you miss something, you have a rise in PSA, you don't know where it is, I think for sure that's the best place for the MR. And these quick slides just show you perfectly answered that the negative predictive value of MR is in the ballpark of 70 to 80%. The positive is still in the 40 to 50%, so it's not great. I can't emphasize that. And even if you look here, that's the precision trial. Everybody knows the New England paper. We get it. And so they looked at biopsying the MR positive versus the standard. We get that. MR identified more high risk and fewer clinically insignificant tumors. We know that. The patients here, you see the two arms, 250 roughly in each of the arm, PSA, classical, 6.5, some family history. And yes, it goes in favor of detecting clinically significant prostate cancer. But PIRATS 3, 22% of clinically significant, but still 12% of significant. PIRATS 4, we should do all. Still 10% of clinically insignificant, even in the precision trial. PIRATS 5, oh my God, 11% of clinically insignificant. And so the message I'm passing here is that I use everyday MR. I think it's very, very helpful. By no means I'm trying to say that you should not use MR. But the point I'm trying to say is that you should not overestimate what MR will bring you, criticize the MR, question, and not base your management solely on that. I think that would be a mistake, and I've heard too many talks where basically MR can replace my dishwasher and they will be equally good, and I don't think so. I can't. Age. The EAU position says that the outcomes of patients who are younger is the same, but younger men needing longer follow-up, there's an uncertainty about their long-term, and certainly young age is not precluding patients from getting active surveillance. And if you look at a recent study from San Francisco with my good friend Matt Cooperberg and Peter Carroll, here 1,500 men. Follow-up a little bit short, that's the criticism, about 49 months. When they compared the biopsy rate in men who were less than 60 years or older, it's interesting to see that the 3 and 5 year biopsy rate was higher in younger men, which is not completely astonishing, possibly because of longer follow-up, but also maybe other factors. However, when they looked at the risk of recurrence, or how this impacted on the survival, there was no difference. And I think it's relatively clear that it's not because Mr. Jones comes in and he's 51. You say, oh, sir, you can't have active surveillance because, your risk of upgrading is much higher. If something happens, you're at high risk. That's not true. What you can tell the guy is that when you will be 70, we don't have the data. It's likely that it will be the same, but we just don't know. So, is there any lower age or upper age? Age, as we all know, is not only the what is indicated on your passport, it's also the way that you behave and sometimes actually the way that you are. We usually would use a 10-year life expectancy to decide on active surveillance. I think it makes no sense to commence an active surveillance if the patient in front of you is highly diabetic, morbidly obese, had 5 MIs, and so on, and where you just plug and play into a life expectancy chart and the guy has 5 to 6 years. It happens. Just don't even bother. There's no point in commencing. You should probably don't even do a PSA, but that becomes another discussion. And there's no influence of race on the decision to do the active surveillance. Let's move a little bit so that we're not too late. The question is BRCA a sign that you should look for more aggressive disease or change the management? We discussed in the first patient. What do we know? We know that patients who have a BRCA mutation will behave very close to the very aggressive tumors. We know from the Pritchard that when you look at people who had metastatic disease, so that's going the other way around, about 12% of these people will have a mismatch repair gene mutation. So more aggressive. We know that when you look at the BRCA tumor and you analyze the genomics of these, and not that I want to show only Toronto, but Paul Boutros and Rob Bristow, who work with us, are actually from Toronto and have done some of the landmark papers on that. They harbor all the old marks, even when they have the same lesion as more aggressive tumor. We know that. Now, we also know that BRCA can distinguish patients who are at increased risk of lethal disease and early age of death. And that was, for instance, a retrospective study where very obviously the risk was much, much higher, but still not that high, 6% versus 1%. So we're not talking about 20%, 30%, 40%. It's a high relative risk, but it's a low absolute risk. And recently, Bal Carter, and that was one of my first questions, looked at the status of the mutation of ATM and others of BRCA1 in an active surveillance cohort. So what did they do? Here it is. They took 2 independent series of men under active surveillance, age 82 and 321, one from Hopkins with a very stringent criteria, the other one from North Shore. The carrier rate is again very, very low, only 2%. So very, very few people. And 11 men of the men who had the mutation had actually a reclassification, so 50%, versus only about 25% in those who didn't. But again, that also means that 50% of men who had the mutation did not progress. And this is not so much different from some of the data from the PROTECT trial and others. And that's why I personally am a little bit cautious about jumping on the wagon to tell the patient, you have a BRCA mutation, you had a Gleason 6, something needs to be done. It's fair to tell him that data suggests that his disease has the same aggressiveness at times than more aggressive. It's fair to say that he might be slightly at increased risk, and we have the data, but it's also fair to say that not everyone who has a mutation will progress. And yesterday, David Margell, who is back in Tel Aviv and who spent 3 years with us in Toronto, has accrued a specific group of BRCA mutation in his population, 14, which is actually even more than the 11 from the large Johns Hopkins series out of 1,000. And look, very short follow-up, and that's certainly something that needs to be highlighted. But only 2 out of 14 were reclassified. So for me, respectfully, the jury is out. I disagree with the idea that we should scare patients telling them that there will really be a lot of problems with BRCA. We just have to highlight that there's a risk of progression that probably is higher than in the rest, and it's up to them to decide what to do. That's the incidence of upgrading. You clearly see the difference between the two. Ourselves, you may remember we had published this large series where we look at the new germline mutation. It was in the gene close to the PSA, which is the kallikrein 6, and where we used the European randomized screening study from the Swiss arm, the PLCO from the US, and our Toronto series, and showed that new genes like the kallikrein 6 are putting patients at higher risk. We're currently doing a much larger study, and I'll be happy to report when it's done. The follow-up. Who sees patients every 3 months the first year? Okay, every 6 months. Once a year. Once a year. Any may I attempt to ask you?
We all receive them once a year physically, but we follow the PSA censorship 3 months.
Okay.
Due to the mutation in
Can I ask you from Denmark? Okay. So you have a PSA, but you don't perform a DR. Okay. I think it's fine. To be honest, it's not as sensitive as it's recommended, but I agree. And so here it's at least once every 6 months, and a DRE at least once a year, as you said. MRI cannot be used as a standalone tool to trigger follow-up biopsies. Again. Biomarkers. The EAU says that all these new fancy biomarkers are promising, but basically they have not been prospectively validated, and therefore, while they're awaiting some of the results, they can't make any recommendation for their routine use. So the big question here, of course, is how do we pinpoint the bad actors, truly? What's the... You have serum markers, like 4K, 5 PCA-free test, which is the urine. You have the multiparametric we discussed. You have then the tissue-based markers, which is the Cypher, Oncotype, and you have, of course, the germline variants. Now, we all know the challenge. The challenge is that the biopsy is a small amount of tissue. There's tumor heterogeneity, and so whatever you'll find as a biomarker may or may not be representative of the most aggressive part of the cancer. Oncotype is one of them. And if I summarize for you, Pluralis uses RNA expression of a 46 gene test, and a low gene expression is associated with a low risk of progression. Who is using Pluralis on a systematic basis here? I know that Sigrid does in New York. So maybe I'm actually proud to start first by asking who nowadays, when you have a patient with an active surveillance in 6, would order a tissue-based like Pluralis or genome-based for the cycle? No. Okay. Then I'll just explain, and I won't go too details. Likely, yeah. We probably have a little bit of a difference because we basically have a lot of those patients, I'm sure in New York, where we base our management on that. And I think that's going to be the future. Oncotype DX is also RNA, 17 genes, and Decipher is 22. And so one of the confusion, if I were having a more North American audience here where many people would use it, the confusion is that the Pluralis is the only one that has been tested for active surveillance. Decipher, Oncotype have been tested, but they've been tested for the risk of upgrading. They've been tested for more aggressive disease. They've been tested for prostate cancer mortality. They have not been tested for active surveillance. And I have also to admit that I use Decipher. So I'm stupid because I use a test which has not been validated in active surveillance, and I draw the conclusion from what I know in other type of cancers that it would apply to the active surveillance. And that's basically the key message I want to say here. Decipher here is, at the end of the day, you take biomarkers RNA based on the tiny amount of the tissue which is dissected. And of course, these cells, in order to be aggressive, need a lot of pathway from cell differentiation, modulate the immune system, progress, and all these are captured in these fancy tests. The only data that we have about Decipher for candidates for active surveillance come from Stacy Loeb, also in New York, but NYU, presented 2 years ago. Here are the 4 risk categories: low NCCN, intermediate favorable, intermediate unfavorable, and high. So basically Gleason 6, Gleason's 3+4, 4+3, and more. And what you see is that once you go, who are the patients that you would consider for active surveillance? The low, or eventually the intermediate favorable, correct? In the low, you still have 17% of high-grade signature. And in the intermediate favorable, 30% of signatures. So very obviously, this helps us somehow pinpoint a group of people where the tissue looks like lesion 6, but the biology may eventually be more in keeping with a more aggressive disease.
Sorry, it's a new for me, but this is the tissue analyzed in the first biopsy or in the second biopsy. Usually it's the first biopsy, but that's when you are to the result from the pathology might have changed a little bit. So still, for example, if you take the tissue at that time, the disease hasn't progressed, so your analysis in biological or at molecular level is still at the earlier stage.
Yeah.
Rather than a new one, unless you read it in a second biopsy, and then you do the DNA or RNA.
Yes, but you're right. But the way that things are moving nowadays is slightly, because you and me, a lot of patients do MMR, correct? We end up more and more with patients with MMR lesion. They are still alive, still in lesion 6. And you're then facing a patient where you have an MMR visible lesion, a lesion 6, and you try to advise whether this patient should go for active surveillance, focal therapy if the lesion 6 is identified, or something else. And I think the place up front of many of these tissue-based markers is to know whether what you have is a real sheet or is a woven sheet. And that's why.
Hi. A few slides ago you were saying that BRCA2, not that good, half the people will do okay.
Yeah.
Now this isn't perfect either, and yet you're really in favour of this. I'm not really quite sure why you should have a different viewpoint concerning the two tests.
So, first of all, I apologize if I even have appeared to favor one of the two, which is actually not the case. I was just disclosing that although it hasn't been studied for active surveillance, for very practical purposes, because that's the test we have in Toronto, we order it. And I was just simply outlining that I do things which are not completely scientific based as well as all of you. And I was simply pointing out the limitations. By no means I was trying to say that I would use this all the time, because the area under the curve of these tests is around 0.80. So you're still wrong in 20% of the cases. Yeah, Sigrid.
Just a comment on this slide. So what I think, to me, this shows, first of all, there's massive heterogeneity. You see, even though you have the low, intermediate, and high-risk groups clinically, then when you add these biomarkers, you see that, there's massive heterogeneity even among the risk groups. But the question is, does it change your management? Do you change anything? So this is the way I see it. If a man has a high-grade disease, we know pretty much what to do. We do radiation or surgery or a combination. If a man has low risk, the default for me is active surveillance. But if you have then, you're unsure, you're at the border of recommending treatment or active surveillance, and then you do a tissue-based biomarker that shows that the risk is higher, especially in the low intermediate risk groups where you're usually uncertain, then it might tip you over to recommend treatment. But I'm not sure if this red here in the low risk would necessarily say you need treatment. It just means that there might be a higher risk and you need more increased vigilance for that patient. But does it change your management? It's not necessarily so. So that's why it becomes, difficult and more nuanced to use these biomarkers. But I think the space where they can be used mostly is when you're at the border of treatment, no treatment. Because there's also heterogeneity. If you do the test on different biopsy tissues, there could be different results based on which biopsy.
I agree, and I think none of these tests are perfect, and I think do an MRI on that as well. I mean, to rely on that by itself, I think, would be a mistake, as you say. But it still gives us, in the whole context of the patient, something that we can look at and something that we can use to help decide what we're going to do, having had a chat with the patient about the risk.
Exactly. You take everything into account. The nice thing is when it comes back in this category, when it confirms that it's low risk, because then you can provide reassurance. But it's an expensive test to provide reassurance.
But just, and I think Sigrid's point is absolutely valid in that patient group. I mean, we treat patients. I don't only do presentations, thanks God. I treat patients like you. And so those patients often come with the MR, correct? They often come with diagnosis. And they often want to know more about the risk of progression and whether truly they're Gleason 6, especially when you are, you have the core which is 40, 50%. You're borderline of active surveillance, although you are a Gleason 6. And the guy's 51, 52, you're hesitating, you don't want to jump on a treatment, but at the same time you don't want to miss. And there's a possibility of now doing focal therapy, for instance. I think this is often where we have our grants, our trials, and where we often discuss the place of these markers, because the active surveillance patient where there's no doubt, we carry on, who needs a test. It's in the in-between patients that these tests, pending that you agree that you may be wrong in 20% and that you accept and the patient accepts. But I personally think that 80% is still better than 50% and is still better than 0%. I would say that any time when we have a Gleason 6 from a MR visible lesion, I ask. Anything, yeah, I'll tell you the truth. We don't biopsy bios free at all. At all. So we biopsy only bios 4, which are the same as the 5, as you know, just as a matter of length of the cord. And that's where we usually ask for more. Sigrid, as you know, had published this paper about the place of the 4K test to pinpoint more aggressive disease. So some people are actually using a 4K test. In other words, if your 4K test is very elevated, you have a patient who is an active surveillance patient, but you have a very high risk of harboring potentially a Gleason 7 or more, you may have eventually to ask yourself whether, you're really dealing with a sheep or not. And then, again, not that I want to be very pessimistic, but when you look at the effectiveness of the 4K, for instance, that's the Canary Pass trial, 700 men. The 4K improved, yes, but it went from 0.74 to 0.78. That's not, it may be significant, but it's not very clinically relevant. And that's the problem of all these tests. When to switch, and I'm going to say one thing quickly for sake of time. The exit strategy is safe. We basically looked here at our series from Toronto, and we matched patients who were under active surveillance versus patients who were presented up front. There is absolutely no difference. So I think that once you decide on treatment, the exit strategy is safe. Monitoring, very busy slide. No one should read that slide because it's all over the map. I just don't think that people have a very clear cut how to monitor people. What we know is that we have to have the repeat biopsy confirmatory at 1 year, that you have a rapidly rising PSA, you should exclude something else, an MR for an anterior tumor, an MR for something that was not detected. We know that repeating the biopsies for the great upgrading over time is probably a good idea, but I don't think that anyone on earth knows when. Many people do it every 3 years. We do it every 3 years. And if you look at here, when to rebiopsy again, it's all over the map. I think it's safe to say that if you do it at least every 5 years and you monitor with the DRE and the PSA and maybe the MR, although you cannot stand on the MR alone, it is safe. We also know it's not because you have a negative confirmatory biopsy that your patient is completely out of the woods, because there's still a risk of upgrading. And finally, when to end the PSA. I'll skip that, but I found this paper really interesting. It's part of the November Gap-Free Consortium, a lot of patients, 21 centers in 12 countries. I don't remember exactly, I think it was close to 4,000 men. What's interesting is that within 5 years, we have a consistent amount of patients who drop out of active surveillance, close to half, 43%. But what is interesting is that only 20% dropped because of disease progression. There is still 12 to 13% of people who will drop for whatever reason, whether they're anxious, whether their physician is anxious, whether both of them are anxious can be a cause. And so, yes, there is progression and people switching. The progression is the main cause of switching to active treatment, but it's not the only cause. And I personally think we should work on these 12% of men who were treated and probably didn't need to be treated, and we should probably do better as physicians with our patients and the patients' advocacy to avoid that. So I'm going to conclude here so that we have time for a break of 15 minutes and have time also for Sigrid and for the cases. So active surveillance, I showed you, has evolved quite a lot since many, many years. And selecting the right patient and the right management is still tricky and error-prone, for sure. I've shown you that even at 10, 15 years, if especially you look at Gleason 6 prostate cancer, the long-term data are robust. They're supported by a randomized study. Pinpointing the bad actor, though, is difficult from the get-go, right off the bat. And I think we still need, whether it's the Decipher Polaris test, whether it's some of the new markers, whether it's the genetic markers. I don't know what's going to be the future. I suspect a combo, but I just don't think we know yet exactly how to individually advise this patient. And we do know that high-volume Gleason 6 is a surrogate for more aggressive disease and also risk of progression. We also know, I showed you, that although the risk is not huge, a small amount of Gleason 4 definitely, and especially at 15 years, conferred a high risk of METs and probably death. And finally is that MR plays a role. We use MR, but we should learn more about the limitation and not use it as a magic bullet for our patients. Thanks so much. Why don't we have a 15-minute break? And Sigrid, who is absolutely an amazing speaker, will carry on with the screening part. Thank you.